I'm here to talk about COVID-19. I do have to say that it's a rapidly evolving subject, and we're constantly needing to adapt our management strategies as we get to know more about the disease. Over the next 45 minutes or so, I'm hoping to go over the proximal origin and pathophysiology of SARS-CoV-2, summarize the current situation at the global level, talk a little bit about viral shedding and transmission, and finally discuss the clinical spectrum and management strategies of COVID-19. Please feel free to ask questions in the chat room. We should have some time at the end to address them. So how did this all start? It started when a cluster of cases of viral pneumonitis of unclear etiology were identified in December 2019 in Wuhan, which is the largest city in central China. A good number of these cases had a connection with the Huanan seafood wholesale market, where live wild animals were sold in addition to seafood. Now, they were mostly food handlers. These patients were very sick. They had hypoxic respiratory failure, ARDS, were intubated, and deep sequencing of the lower respiratory tract cultures identified a novel coronavirus. Now, coronaviruses are large, enveloped, single-stranded RNA viruses. Their structure consists of a nucleocapsid protein, a membrane protein, an envelope protein, and a spike protein. Now, the spike protein is very important because it has the receptor binding domain, which allows the virus to attach to specific receptors on the host cell for entry as well as for viral replication. Now, there are 4 genuses within the coronavirus family: alpha, beta, gamma, and delta. Alpha and beta coronaviruses are derived from the bat gene pool and are pathogenic to humans and mammals, while gamma and delta coronaviruses are derived from the avian and the porcine gene pool. Now, the novel coronavirus got named as the SARS-CoV-2, and it got classified as a beta coronavirus belonging to the subgenus SARS-CoV-virus. Now, how did this happen? The main reason for this is that the genomic sequence of SARS-CoV-2 was found to was found to be 98% similar to that of coronaviruses found in horseshoe bats. The genetic sequence was about 79% identical to the original SARS virus and about 50% identical to the MERS virus. It did have a couple of unique features, and I want to now go back to the spike protein. The spike protein consists of 2 subunits, the S1 subunit and the S2 subunit. The S1 subunit has the receptor binding domain, and it was found that in SARS-CoV-2, the receptor binding domain was optimized to combine to the human receptor ACE2, just like the original SARS virus, but the affinity is 10 times stronger. Comparative analysis with other known coronaviruses showed that the sequence was very similar to that found in Malayan pangolin coronaviruses. Now, the second unique feature of this virus is the sequence of the polybasic cleavage site, which is present at the junction of S1 and S2 subunit. Now, this sequence has never been identified before. It's brand new. And I'm not going to go too much into its detail, but I do want to mention that this site determines viral infectivity and host range, and likely provides some explanation as to why SARS-CoV-2 has been able to spread to such pandemic proportions. So here's a very quick and simplistic summary of what may have happened. SARS-CoV-2 likely originated in bats. At some point, it jumped to pangolins and acquired the high affinity human ACE2 receptor binding domain. Then it jumped to humans, mutated at the polybasic cleavage site, which allowed for rapid and efficient human-to-human spread. Now let's talk a little bit about the pathophysiology of SARS-CoV-2. It is well established that the human ACE2 receptor serves as an entry point for SARS-CoV-2. Now, once the virus enters the cell, it downregulates the surface ACE2 receptor, which plays a very important role in immune regulation. There is a very high concentration of these receptors in the oral and nasal mucosa. So this allows for very easy access to the virus. There is also a very high concentration of ACE2 receptors in the lungs, the heart, blood vessels, kidneys, and GI tract. And clinically, we are seeing that these are the organs that are primarily affected in COVID-19. It also appears that the elderly are more prone to severe manifestation of the disease compared to children. And this may be partly explained by a very robust and efficient T cell immune response in children that helps with viral clearance. As people age, what happens is the concentration of the ACE2 receptors in the organs decreases, leading to a potential unregulated inflammatory response that can cause tissue damage. Now, there is some thought about, as we've noticed that patients who have comorbidities such as high blood pressure, diabetes, coronary artery disease, who are on ACE2 inhibitors can cause an upregulation of ACE2 receptors, allowing more access for viral entry and viral replication. Now, in the lungs specifically, ACE2 receptors are located in the distal airways and on the alveolar cells. Now, especially on the type 2 pneumocytes. Now, the main function of type 2 pneumocytes is surfactant generation and alveolar repair. When these cells are compromised, there is an imbalance between pro-inflammatory and anti-inflammatory processes that can lead to lung injury and ARDS. Now, autopsy results in patients who have died from COVID-19 complications have provided some insight into the pathophysiology as well. So if you look at the lungs, they look grossly edematous. There are diffuse congestive changes, and there are also changes that are consistent with hemorrhagic necrosis. And there are a variety of histological findings in the lung that are very consistent with ARDS, such as if you see here, there is necrotizing bronchiolitis, there is atrophy of alveolar epithelial cells, hyperplasia of bronchial epithelial cells, hyperplasia of alveolar epithelial cells. Here you'll see thickening of the alveolar septum and infiltration with cells such as lymphocytes, monocytes, and plasma cells. There's desquamation of the alveolar epithelial cells, fibrinous exudate in the alveoli. Here, if you follow my arrow, you can see multinucleated giant cells. And also over here, you can find evidence of intracytoplasmic viral inclusion cells. Now, interestingly, there has also been some evidence of small vessel hyperplasia with vessel wall thickening, luminal stenosis, and occlusion with microthrombi. I don't have a picture for that, but multiple reports have shown this. And these findings are present not just in the lung, but also in the heart, kidneys, and other organs. We will get to the potential significance of this in a bit, but I did want to mention that while I talk about the histological findings of COVID-19. Now, COVID-19 was declared a global pandemic by the WHO on March 11th, 2020. And this is where we are right now. So globally, about 1.5 million cases have been confirmed. US accounts for about a third of those cases. 184 countries in the world have been involved. Every day, globally, we are seeing about 80,000 new cases. And in the United States, we're seeing about 30,000. But 88,000 patients have died. A significant proportion of those cases are from Europe as well as the United States. Yesterday, we saw a record number of deaths in New York. 780 people died in a 24-hour period. Now, how does SARS-CoV-2 compare to other viruses? Now, in terms of sheer numbers, the H1N1 pandemic had about 1.6 million cases and 284,000 patients died. The mortality rate was very high at about 17%. Now, we're definitely going to cross those numbers with COVID-19. The mortality of COVID-19, though, is thought to be much lower. WHO calculated it at about 3.4%. But remember, it's probably a little bit of an overestimate because it does not account for mild and asymptomatic cases. In general, the mortality rate with COVID-19 is thought to be anywhere between 1 to 2%. Now, when we look at the other coronaviruses, like the SARS and the MERS epidemics in 2002 and 2012, respectively, the numbers were much, much, much lower. SARS, the original SARS epidemic only had about 8,000 cases, but the death rate was much higher at 10%, and 800 people died. The MERS epidemic was even smaller, only 2,500 cases, about 850 patients died, and the mortality rate was much higher at about 34%. Some of this has to do with the R naught, or the basic reproduction number. The estimates for COVID-19 have been around 2 to 2.5, but more recent estimates have been higher at about 3.4, 3.5. And this basically means that the virus is, one person with the virus is able to spread it more efficiently to other people. One person can spread to about through three others on an average. The R naught with SARS-CoV-2 probably is higher than the original SARS virus, simply because of the extent of spread that we are seeing with COVID-19. Now, in this next section, I just wanted to discuss some key aspects of SARS-CoV-2 viral shedding and transmission that has allowed it to spread rampantly across the world. Now, this is the first case of COVID-19 that was reported in the United States on 28 Jan. The patient had just returned from Wuhan and clinically had fever, cough, and fatigue mainly. Also reported some GI symptoms like nausea, vomiting, and abdominal discomfort. When the nasopharyngeal and oropharyngeal swabs were checked for COVID-19, it looked like the viral counts were much higher at the time of symptom onset, and the counts were also much higher in the nasopharyngeal swabs when compared to the oropharyngeal swabs. Interestingly, the stool of this patient was also found to be positive. Now, droplets and aerosols are thought to be the predominant mechanism by which this virus spreads. The stool positivity is more likely to be reflective of the virus affecting the ACE2 receptors in the GI tract rather than it having a major role in fecal-oral transmission. Now, in this study, the pattern of viral shedding was looked at more closely. Nasal and throat swabs were collected from 18 COVID-19 patients over a 20-day period. And what they found was the viral loads were much higher in the nasal swabs compared to the throat swabs. And it also appeared that the viral shedding was much higher at symptom onset as compared to later on in the course of the disease. Now, very concerningly, there was one asymptomatic patient who had a viral shedding pattern and a viral load pattern that was very similar to symptomatic patients, which basically means that asymptomatic patients were very capable of transmitting the virus. They were as good as symptomatic patients. Now, this pattern of viral shedding was actually very different from that noted at the time of the original SARS virus. Now, if you look over here, the viral shedding with the original SARS epidemic was low at the time of symptom onset and peaked when symptoms became severe. So more likely when the patient was hospitalized and unable to transmit the virus as efficiently. And this could potentially explain the difference in the extent of the two epidemics. Now, there have been several clusters that have been reported that show or prove asymptomatic transmission, rather. I just wanted to highlight this particular one. Um, uh, a Chinese businesswoman basically flew to Germany to attend a conference. She was there for 2 days. She was asymptomatic at that time, attended business meetings, and on the way back to China, developed some symptoms. On reaching China, she was diagnosed with COVID-19. Now, during the 2 days that she was in Germany, she passed on the virus to two of her colleagues, who in turn passed on the virus to two of their close contacts. Now, the patient zero had very mild symptoms, and the symptoms resolved in a couple of days. But when they looked at the viral load in the sputum sample after symptomatic improvement, there was still a very high viral count. And this is very concerning because it appears that asymptomatic patients can transmit the virus, and the virus can be transmitted even after symptomatic resolution. Now, this paper was published in the New England Journal of Medicine, where the surface stability and aerosol stability of the virus was looked at more closely. It appears that the virus can last in aerosols for less than 4 hours. It can last for about 4 hours on copper surfaces, up to 24 hours on cardboard, and up to 4 days on stainless steel and plastic. Now, let's talk about the clinical presentation of COVID-19. The incubation period of SARS-CoV-2 is thought to be somewhere around 4 days, and it ranges between 2 to 7 days, and it can be up to a max of 14 days. Patients predominantly present with fever, cough, shortness of breath, myalgias. Now, in this paper, fever was present in about 99% of the patients. There was another paper published in New England Journal of Medicine where, at the time of hospital admission, only 44% of the patients had a fever, but during the course of hospitalization, about 90% developed the fever. So there's been some concern about whether fever should be included as one of the diagnostic criteria. Several atypical presentations have been reported so far. We have encephalitis, conjunctivitis, anosmia, dysgeusia, cardiac arrest, ventricular arrhythmias, DIC, a predominantly GI pattern or a GI presentation as well. Those seem to be more on the rarer side. Now, this paper also showed that about 40% of the cases were likely due to nosocomial transmission. 10% occurred in hospitalized patients and 30% in medical staff. Now, it's not very clear if these numbers are accurate because this study was done at a time where there was widespread community involvement. So it's unclear if the medical staff or the patients got the virus in the community or while working in the hospital. Now, 80% of the patients who have COVID-19 have mild symptoms. 20% need hospitalization, and 5% of those 20% need to be admitted to the ICU. Now, this graph shows the clinical course and ICU admission and the viral shedding pattern of survivors and non-survivors. And if you look closely, the pattern is very similar between the two groups. It appears that at about day 8, day 9, patients become more dyspneic and develop hypoxic respiratory failure. It occurs in about 20% of the patients. Age greater than 60 years, male gender, and comorbidities such as diabetes, malignancy, immunocompromised status are risk factors for hypoxic respiratory failure. The progression of hypoxia can be very rapid within 12 to 24 hours. Median time to developing ARDS is 8 to 12 days. Median time to mechanical ventilation is between 10 to 14 days. And median time to VAP development in intubated patients is about 8 days. Now, very clear patterns have been observed in terms of lab findings between when comparing non-survivors and survivors. It looks like non-survivors had a higher WBC count, a higher neutrophil count, a lower lymphocyte count, higher BUN and creatinine, and a higher D-dimer. And patients who were admitted to the ICU had elevated cardiac enzymes, elevated procalcitonin, elevated LDH, and abnormal LFTs. Now, when we look at the clinical course of these patients, coming back to this slide, we can think about the disease as three stages. The first stage is a phase of viral replication and infection, where patients tend to have mild infection. The second phase is the pneumonia phase or the hypoxia phase, which could be because of a combination of viral replication and poorly regulated immune mechanisms. Now, this typically seems to occur around the 7 to 10 day point. And the third stage is the hyperimmune stage, where a lot of the lab abnormalities that I have reported over here can be seen. There's elevated D-dimer, elevated ferritin, elevated CRP, LDH, cardiac enzymes, etc. And we will touch about these three phases a little bit more when we're talking about the management strategy in these patients. I do want to touch a little bit about coagulopathy. 50% of the non-survivors had a coagulopathy in this paper, which defined it as a 3-second extension of the prothrombin time and a 5-second extension of the activated PTT. Non-survivors had a significantly lower platelet count, a higher prothrombin time, higher D-dimer, higher ferritin, and a higher IL-6 level. 71% of the non-survivors had DIC as well. Let's talk a little bit about myocardial injury. Now, there have been certain hypotheses as to why coagulation defects and myocardial injury can occur. It could be because of direct viral toxicity, because we know that ACE2 receptors are present in the heart as well as the blood vessels. It could be because of sepsis or systemic inflammation. It could be because of stasis and critical illness as well. I do want to point out that when there is endothelial injury because of, say, the virus, platelets aggregate and microthrombi can be formed. And if you were to look at the coagulation profile of those patients, it would be very similar to a consumptive coagulopathy, or it would be very similar to that seen in DIC. Myocardial injury, we know, can occur because of viral myocarditis. It could occur because of stress-induced cardiomyopathy as well. And it can also occur because of thrombosis and MI. Now, in this paper, what they found is patients who had evidence of cardiovascular disease. So patients with history of hypertension, coronary artery disease, and cardiomyopathy had a higher average troponin level compared to those who did not have cardiovascular abnormalities. And they also found that this correlated directly with mortality. 70% of the patients who had a history of cardiovascular disease and an elevated troponin level did not make it, as opposed to 37% who had just an elevated troponin level without history of cardiovascular disease. 13% of the patients who, the mortality was 13% in patients who had who had just a history of cardiovascular disease without troponin abnormalities. Now, if you look at the graph at the bottom, patients who died from COVID-19 had a progressive rise in troponins as well as pro-BNP. This could be just suggestive of a rise secondary to myocardial injury from systemic inflammation. Now, 50% of the patients died because of respiratory failure, and 33% of the patients died because of a combination of respiratory failure and myocardial damage. Now, if you look at the time to death, it looks like there are two peaks. One is around the 14-day point. This this could be this could be mortality because of ARDS or because of coronary um, uh, like myocardial manifestations like arrhythmias, cardiac arrest, etc. And the second peak seems to occur around the 21-day point. And this likely occurs because of unresolved AKI, because of thrombosis, coagulopathy, myocardial injury, DIC, a cytokine storm, etc. Now, the original mortality rate that was reported from data in China was around 2.3%. This was very different when compared to the mortality rate in Italy. So, this paper looked at mortality rates stratified by age. And what they found is the rates were very similar in the 0 to 69 age group, but shot up in the 70 to 79 age group at 13%, and in the greater than 80 years age group, it was about 20%. Now, this is probably because of the way the cases were, the age distribution of the COVID-19 cases in Italy. 37% of the patients in Italy were over 80 years of age, as opposed to 12% in China. And the societal structure may also be partly responsible, because a lot of the elderly in Italy lived with their children, so they were more likely to get exposed to the virus as compared to that in China. Now, patients who have a history of heart disease had a mortality rate of about 10.5%. Patients with a history of diabetes, chronic respiratory disease, high blood pressure, and cancer also had relatively higher mortality rates. I wanted to go over a few of the CT scans. Now, the first one is this one. This is your classic COVID-19 CT scan, where you'll find patchy ground glass opacities that are peripherally located in the lower lobes. The infiltrates have more of a rounded morphology. As these ground glass opacities coalesce, they form infiltrates, which are more peripherally located again and more in the lower lobes. This CT scan shows ground glass opacities that are following bronchovascular distribution. If you follow the arrows, you'll see that the airways are located within the ground glass opacities. This is a CT scan that you're more likely to find in severe patients later on in the course of the disease. It's dense infiltrates with air bronchograms. This is the reverse halo sign, where you'll see ground glass opacities in the center and peripheral attenuation. It's also called the atoll sign. And this is the classic crazy paving, where you'll see a reticular pattern with interlobular sepal thickening. This is more likely to be seen in severe disease. Now, I wanted to talk a little bit about this study that compared CT chest findings to RT-PCR. Now, about 1,014 patients who had a CT scan and RT-PCR within a 7-day period were looked at. And what they found is 580 patients had a positive RT-PCR and a positive CT scan. 308 patients had a negative RT-PCR and a positive CT. Now, among these patients, 48% had findings that were classified as being highly suggestive of COVID. 33% were probable cases, and 19% were uncertain cases. 21 patients had a positive RT-PCR and a negative CT scan, and 105 patients had a negative RT-PCR and a negative CT scan. Now, when they calculated the sensitivities and the specificities, remember, this is CT scan compared to RT-PCR, the sensitivity was about 97% and the specificity was about 25%. They also looked at how the CT scan performed in different age groups, so less than 60% and over 60%, and how it performed in males and females. And for the most part, it seemed like it was very similar. Now, there are limitations. The main takeaway point from this study, I think, is that in areas where RT-PCR is not readily available, CT scan may actually be a good screening tool. The issue is that there's no gold standard. We know that RT-PCR has a low positive rate. The numbers that have been thrown around are about 70% sensitivity. So The CT scan sensitivities may be overestimated and the specificities may be underestimated just because we're comparing CT scan findings with RT-PCR. Now here I wanted to show chest ultrasound findings. Now, what you predominantly see are diffuse or focal B lines with pleural irregularity. Now, the ultrasound findings are very suggestive of the CT findings. If the disease is very extensive in the CT scan, then you're more likely to see diffuse B lines. And if the disease is more focal, you're more likely to see focal B lines. Now, if you look here, this is just a more close-up where you'll appreciate the pleural irregularity a lot better. Just play it once more. Now, this is a test I think that we're all eagerly waiting for. It's a rapid IgM-IgG combined antibody test. I want to say that several groups are actually developing this test, and I only found this one paper published by a group from China. I do know for a fact that this test is actually available. It costs about $250 per test. The sensitivity was found to be about 88%, and the specificity was found to be about 90%. The test performed pretty similarly when done on fingerstick blood or when looked at with serum and plasma. It's a point of care test and the results are available in 15 minutes. The authors did conclude that using a combined IgG-IgM antibody test will allow for more accurate detection of patients with a prior history of COVID-19, as opposed to just doing an isolated IgM or IgG test. Next, let's talk about the management strategies. Now, this is what I was sort of alluding towards previously. Now, the COVID-19 disease can sort of be looked at as a three-stage process. The first stage would be the one where there is viral replication and infection, and using drugs such as remdesivir, chloroquine, hydroxychloroquine, which would inhibit viral replication, would make sense. Now, the second stage is the pulmonary phase. Patients become hypoxic. It can be divided into stage 2A and stage 2B. Stage 2A would still have some of that viral replication, but stage 2B, it's more likely to taper off. So when you look at the drugs that potentially may be helpful, use of immune modulators or immunosuppressive agents, later part of stage 2 may have a role. Stage 3 is clearly a hyperimmune phase, and using IL-6 inhibitors, steroids, IVIG, etc., may prove to be beneficial in this stage. Now, talking about COVID-19 specific drugs, the first one is chloroquine. Now, there's actually no human study that has actually been published that I could find in the literature. With the original SARS epidemic, chloroquine was looked at, and as you can see in vitro studies, it clearly showed the capacity to suppress viral replication. It's an anti-inflammatory and an antiviral agent. It increases endosomal pH, inhibiting viral cell fusion. It also interferes with the glycosylation of cellular receptors of SARS-CoV. In a letter to the editor, I found a reference to a study that had 100 patients, which was done over 10 hospitals in China. And chloroquine was found to be superior to controls in inhibiting the exacerbation of pneumonia, in improving lung imaging. It also allowed for faster virological clearance and a shorter disease course. The letter also stated that the safety profile of chloroquine was good. Now, hydrochloroquine is sort of chloroquine's cousin. And when they compared hydrochloroquine to chloroquine in vitro studies, this is actually a paper that was published relatively recently, hydroxychloroquine was found to be more efficacious in suppressing viral replication when used as a treatment or as a prophylactic dose. Now, it's also an anti-inflammatory and an antiviral agent. It inhibits viral entry and viral release into host cell. It inhibits viral infectivity, and it's an immune modulator. Now, the only study that I could find with respect to hydroxychloroquine is this one. It was a very small randomized control trial where 31 patients were randomized to receive hydroxychloroquine and 31 patients were randomized to the control group. And the outcome measure that they looked in this study was actually changes in CT scan. And they found that CT scans in patients who received hydroxychloroquine were much better compared to those who received controls. So we really don't have a lot of evidence in terms of the benefits of chloroquine and hydroxychloroquine. In vitro studies have clearly shown a possibility of use, but that doesn't necessarily translate to in vivo studies. Now, this is the paper that sort of suggested that hydroxychloroquine and azithromycin may have a synergistic effect in controlling viral shedding. If you look at the top graph, by about day 4, day 3, the group that received hydroxychloroquine, a significant number of patients had a negative RT-PCR. When you look at the bottom graph, the green line is reflective of patients who were on hydroxychloroquine and azithromycin. And the graph looks pretty impressive. But the study had a lot of limitations. The first one is that the study was actually designed to look at the efficacy of hydroxychloroquine compared to standard of care. The second one is that it's a very small study. N was only 42. Hydroxychloroquine group had 26 patients and the control group had 16 patients. 6 patients were lost to follow-up, out of which 4 patients had a positive RT-PCR at the time of loss to follow-up. 3 patients were transferred to the ICU, 1 died, 1 left the hospital, and 1 stopped because of nausea. Now, the other aspect to the study is also that azithromycin was not given as part of the study protocol. It was given to 6 patients at the discretion of the treating physician. If the patient had lower respiratory tract symptoms, the patients were more likely to get azithromycin compared to the other patients. I think we have to be very cautious about using this as a combination simply because both of these agents are known to prolong QT. Now, this is the Calitra trial that was published in the New England Journal of Medicine. The results were very disappointing. The outcome measure was time to clinical improvement, and there was no difference between the group that received Calitra as opposed to the group that received standard of care. When they did a modified intention to treat analysis, where 3 patients who died before receiving Calitra were excluded, there was a significant difference in the time to clinical improvement, but the difference was only of 1 day. So not necessarily very helpful. A whole slew of secondary outcomes were looked at, such as 28-day mortality, ICU length of stay, hospital length of stay, viral shedding, etc. And there was no difference between the Calitra and the standard of care group. Now, this paper looked at the potential role of tocilizumab in COVID-19 patients. It was a small study, included about 21 patients with severe and critical COVID-19. It was published in a Chinese journal. A few things to keep in mind is that these 21 patients were also being treated with antivirals as well as steroids, and all of them had an elevated IL-6 level. And if you look at the graphs, it's very, very impressive. Patients had a pretty dramatic improvement in their CRP. The fever curve effervesced pretty quickly within a day. The oxygen requirements also came down. And when CT scan findings were compared pre and post tocilizumab, it looked like the patients had pretty dramatic improvements in the CT scan findings as well. Lymphocytopenia also improved, and procalcitonin levels were found to increase as well. Now, the study had some limitations. in terms of the fact that it was a small study, it wasn't a randomized controlled trial, and the influence of antivirals or steroids in the outcomes of these patients is not known. Nevertheless, we do have there is an ongoing IL-6 study in the United States. Tocilizumab is one agent, and sarilumab is the other agent that are being looked at. These are large, multi-center, randomized controlled studies. This is another paper that I found looking at the effect of convalescent plasma in 5 patients. These patients were critically ill. They were also being treated with antivirals and steroids. These patients were being treated in China. The convalescent plasma dosing was done anywhere between the 10th to 22nd day of admission. And as you can see, the viral shedding decreased dramatically. The SOFA scores improved, patients' DEFA-Vest and the P2F ratio also improved. Again, it's a very small study, and we do not know what influenced the antivirals or the steroids or the other treatment that was modalities that were being given to the patients. A lot of these patients were also being given IVIG and IL-6 inhibitors. I just wanted to touch a little bit about antibiotics. About 10 to 20% of the patients tend to have secondary infections, and this paper showed that 50% of the non-survivors had findings suggestive of secondary infections. A third of the patients who were on mechanical ventilation developed VAP, and as I mentioned before, the average time to developing VAP was 8 days post-intubation, and the median time to developing secondary infection is about 17 days. So patients who are sick, who are critically ill, should be treated with ceftriaxone and azithromycin for CAP coverage. If patients have risk factors for MRSA or Pseudomonas infections, then they should receive vanc or Zosyn or cefepime. Having said that, aggressive discontinuation is recommended if the cultures remain negative around the 48-hour time point and if procalcitonin levels are low. Now, what is the role of steroids in these patients? Now, this is very controversial, because when you look at the data in the SARS, coming from the SARS, MERS, and the influenza epidemics, it looks like steroids increase mortality, they delayed viral clearance, and increase the risk of secondary infections. I think at this time, if the patients have findings suggestive of COPD or asthma exacerbations, or the patients have refractory shock, or the patient has been on chronic steroids and is requiring pressors, it's very reasonable to give steroids. The use of steroids in the hyperimmune phase is at the discretion of the physician, and this study may provide some guidance. Now, the study looked at the risk factors for developing ARDS, as well as the risk factors for the progression of ARDS to death. And they found that age, higher fevers, neutrophilia, elevated LDH levels, elevated IL-6 and D-dimer levels were associated with progression of ARDS to death. Now, when they looked at the mortality in the group that received methylprednisolone versus the mortality in the group that didn't receive methylprednisolone, there was a significant difference. 46% died in the methylpred group as compared to 62% in the non-methylpred group. So there seemed to be a mortality benefit. Having said that, this was not a study that was designed to look at the effect of methylprednisolone. These patients were again being treated with a whole bunch of experimental drugs like IVIG, antiretrovirals, etc. Physiologically, when you look at the rise in the inflammatory markers, it does seem like there may be a benefit, but we do not know for sure if steroids are not harmful to these patients as they were during the MERS, SARS, and the influenza epidemics. I do want to touch a little bit about anticoagulation because this has been getting a lot of press lately. Now, this study looked at about 450 patients who had severe COVID-19. 99 patients were receiving heparin and 350 patients were not being treated. with heparin. And when they looked at the mortality between the two groups, it looked like there was a 20% reduction in 28-day mortality in the group that received heparin when the D-dimer levels were greater than 6 times upper limit of normal. Below, for D-dimers less than 6 times upper limit of normal, there wasn't a significant difference, but there clearly seemed to be a trend towards a benefit. In this paper, 71% of the non-survivors had findings that was very consistent with DIC, as compared to 0.6% among the survivors. Lastly, I want to touch a little bit about the SCCM guidelines on the management of pulmonary complications of COVID-19. This is just a summary slide. I strongly encourage everyone to listen to the talk given by Dr. Vivek Murthy. The link to that video is circulated in the daily COVID updates. He provides a more in-depth discussion as to why and how these guidelines came about. For COVID-19 patients in general, the goal O2 SAT is between 92 to 96%. Lower or higher SATs have been associated with mortality in ARDS patients. Awake proning has been shown to improve oxygenation. We don't know if it necessarily reduces intubation rates, but it definitely seems to improve oxygenation. High flow nasal cannula may reduce the need for intubation. We should be avoiding non-invasive ventilation simply because it looks like it just may be a higher risk for, it's a modality that has a higher risk for aerosolization. This is also a little bit of a topic of debate and controversy, but for the most part, avoiding non-invasive ventilation is recommended by SCCM. ARDS-NET protocol should be followed for mechanically ventilated patients, targeting a low tidal volume, around 6 cc's per kg ideal body weight is recommended. Target bladder pressure is less than 30 centimeters of water. A conservative fluid management strategy should be employed. Consider proning for patients with a P2F ratio of less than 150, and VV ECMO can be considered in patients who on a case-by-case basis. And when it comes to weaning off the ventilator, it's always recommended to wean off the FiO2 before weaning off PEEP to minimize oxygen toxicity. Now, one of the things that has been very unique to COVID-19 is that a lot of these patients seem to have good lung compliance, and then they seem to be very PEEP responsive. And oxygen saturations improve pretty dramatically after intubation. However, even though they meet all the weaning parameters, extubating too soon may not necessarily be the best in terms of their management, because it looks like a lot of these patients require to be re-intubated. The average duration of intubation seems to be anywhere from about 7 to 14 days.